Now you can see a slide from the design of temporary denture. It was intended to be a printed denture placed on a bar attached via intermediate elements to the multi-units. Okay, but patient didn't accept that. Here you can see the temporary printed work. Please pay attention to the large size and vertical dimension of the work. It's also important to remember the high flexibility of the zygomatic implants. Considering all these factors and being aware of the mass, density, and modulus of elasticity of zirconium oxide, from which I initially intended to make the work, I decided to modify the treatment plan. I applied an acrylic work on titanium bar directly screwed in onto the multi-units. A copy of that work was immediately made, which will be screwed in if the currently used one breaks or wears out. The aesthetic effect seems very good to me, and the work itself has been serving the patients very well for a year and a half without any repairs. And see the color of the gums, that this is not unilateral color, as I said you before. In the lower arch, I used 5 zirconia crowns and the bridges on implant. Know that in such situations, the absence of one incisor does not significantly worsen the aesthetic outcomes, because the key is the even length and arrangement of the teeth, not their quantity. In such case, the midline should be projected on the central incisor, on the center of the central incisor. And it looks very well. Okay. The next case involves a man suffering from pathological wear, recurring the strong muscle-related headaches due to improper positioning of the mandibula in relation to the maxilla in the mechanism of narrowed occlusal envelope described by Professor Coyce. We can observe wear within the teeth, especially in the lateral segment, and numerous of wedge-shaped defects resulting from occlusal overloads. The patient also, of course, dreamed about beautiful smile. Overloads is a funny word for me. Here you can see the pathological wear in the lateral segment of the smile, of the teeth. Okay. So we started the procedure by performing a DSD, the results of which you can see here. After acceptance by the patient, we moved to work with the 3D models. Before performing the digital walks-up, in such cases, I registered the occlusion in central relation by creating the element from composite in anterior part of the maxilla, which causes the patient to deprogram. I usually leave the patients like this for a few hours from instructing them to perform exercises. If it's not enough, we should leave the patient like this for the day or two. It's important not to raise the patient too much, but to a height as closely as it's possible to the expected one. This is significant due to anterior movement of the process of jaw retraction. We should register the occlusion so that there is no need to lower the occlusion in the digital articulator. It's also good to check the height and the position of the mandibula obtained this way are comfortable for the patient in the resting lip position, and comply it with the principle of equal height of successive facial level. It's also good to check if the height and the position of the mandibula obtained in this way are comfortable for the patient in the resting lip position. and compare it with the principle of the equal height of the successive facial levels. It's valuable to record the smile using the facial scanner in the obtained relation and occlusion, not in habitual one. It significantly facilitates the procedure. If computed tomography is needed in that cases, for example, to the implantological reasons, this is the best moment to perform it. Okay, and see, here we can see the relation, and here we can see the habitual occlusion. In this case, it's also beneficial to generate the file that allow us to see the project overlaid on the patient's actual teeth. This enables us to precisely plan the extent of grinding so that it is minimally invasive. As I mentioned earlier, it's valuable for such an image to be displayed on the screen in the front of us during the entire grinding process. This is also the moment when it's worthwhile to evaluate the project together with the patient, discussing the entire scope of the procedure and assessing the project from both the front and the profile. This is invaluable for the patient's later satisfaction with prosthetic process. It significantly increases the chances of hassle-free acceptance by the work aesthetics. Also, in the case of potential endodontic complications in areas that requires more invasive grinding, the patient accepts them more easily because they understood their origin. Okay, so here we can see the project, the design. Okay, here we can see the state after grinding registered in the central relation. It's important to remember to register the shape of the teeth before the grinding by performing a pre-scan. So the technician can position the models in the previously registered relation and occlusion by overlaying the different scans. As for the grinding itself, I decided on a mixed work using veneers, crowns, and onlays to keep the preparation as minimal as it's possible. In the most damaged teeth, I opt for the prosthetic crowns. Okay, you can see the photos of the of the work done by the laboratory. Okay, so when we need the registration of central relation, it's important to make the visit using that points. First, we should examine the temporomandibular joint. Then we should make the programmer for a few hours or a day or two. Then we should register the central relation using an intraoral scanner. You should remember to make the pre-scan and the scan with the programmer. Then we should make the facial scan with the programmer. And if it's needed, we should make the tomography with the programmer. So we can make intraoral scan without the programmer now or before attached to the programmer. We can decide. It's not important. Then we should make the diagnostic walk-up and mock-up. Then in that cases, we should fitting the mock-up and observe the patient for a few days. After that, we should reassess our project and make the preparation. Then if it's needed, we should make the temporary crowns to observe the patient if he feel good in that work. Then if we need correction, we can make another facial scans. And after all of this, we can make the final work. Okay. On the next few slides, you can observe the effect of the work on the day after delivery and over the time. The patient is satisfied and he has no more headaches. This is the day after, and this is the month after. I think that is nice.